Good afternoon, everyone. My name is Brian White, and I'm an internal medicine resident and incoming gastroenterology fellow at the Hospital of the University of Pennsylvania. On behalf of my co-authors, I'd like to thank the editorial board and staff for this tremendous opportunity to share our study pending publication in GIE, Indefinite for Dysplasia in Barrett's Esophagus, carries substantial risk for prevalent and incident neoplasia, updated outcomes, and long-term follow-up. I'll start by talking about the purpose of this project and why we thought it was important to do. Barrett's esophagus is a well-recognized precursor to esophageal adenocarcinoma and a target for screening and surveillance programs intended to detect high-risk lesions in early-stage cancers. Dysplasia is one of the strongest risk factors for progression to cancer among patients with Barrett's and represents a threshold for endoscopic eradication therapy. We know that in the absence of dysplasia, the annual risks of progression to cancer are low and merit surveillance at an extended interval. But somewhere around 5% of patients, depending on the estimate, have biopsies labeled indefinite for dysplasia on screening or surveillance endoscopy, wherein certain features preclude a confident histopathologic diagnosis of dysplasia or the absence. There's been limited data on the long-term outcomes of these patients, particularly with respect to the risks of developing neoplasia, meaning dysplasia or cancer. And that's compromised our understanding of the optimal management strategies for these patients. Our group previously studied a smaller cohort of patients with Barrett's indefinite for dysplasia, and we sought to add long-term follow-up and a larger sample to this group. We conducted a retrospective review of 299 patients with Barrett's esophagus and an index endoscopy with indefinite for dysplasia, a finding which was confirmed by expert GI pathology review at a tertiary center. These patients had no prior history of dysplasia, and they had at least one follow-up endoscopy. We followed these patients for the development of either prevalent neoplasia, which was diagnosed within 1 year of the index endoscopy, or incident neoplasia, which was diagnosed at least 1 year beyond the index endoscopy. We performed Kaplan-Meier analysis and Cox and logistic regression modeling to identify risk factors for progression. We found that of 223 patients who had repeat endoscopy within a year, almost 10% had prevalent neoplasia, including 6.7% with high-grade dysplasia or cancer. For patients who didn't have prevalent neoplasia and had a follow-up endoscopy at least 1 year later, over a median of 4.5 years, 22% developed incident neoplasia. Patients developed high-grade dysplasia or cancer at a rate of 1.7 per 100 patient years. Barrett's segment length and smoking were associated with increased risks for neoplasia, with hazard ratios of 1.1 and 2.0 respectively. Patients in our long-term cohort, who were followed for a median of just over 8 years, had a similar rate of progression to high-grade dysplasia at 1.4 per 100 patient years. And multifocal indefinite biopsies were identified as an additional risk factor for progression in this group. Neoplasia was substantially prevalent in this cohort, which really underscores the importance of a close follow-up endoscopy after an initial exam with indefinite for dysplasia. The risks for incident neoplasia were similar to those previously reported in a meta-analysis of patients with indefinite for dysplasia, and also quite similar to those reported in a large meta-analysis of patients with low-grade dysplasia. Current ACG guidelines recommend annual surveillance for patients with persistent indefinite for dysplasia, and our data support this given the similar annual rates of progression compared to those with low-grade dysplasia. For the next steps, we would certainly benefit from prospective studies exploring the optimal surveillance intervals for patients with Barrett's that's indefinite for dysplasia, and potentially stratifying risk by features like segment length and smoking. Our data and that of others suggest that progression rates are variable according to these risk factors. There's also a lot of interest in tissue-based biomarkers to assist in risk stratification, and we're very eager to see what kind of role these might have in influencing surveillance intervals for patients with indefinite. Another feature that's important to highlight here is the heterogeneity in the indefinite for dysplasia label. Patients in our study were deemed indefinite for dysplasia after GI pathology review at a tertiary referral center, so we aren't drawing conclusions about community diagnosed indefinite. Current guidelines recommend indefinite for dysplasia be confirmed with review by a second pathologist with expertise in GI pathology before making a decision about subsequent surveillance. I thank you all for listening and hope you'll give our manuscript a read in GIE. If you have any questions or comments, please don't hesitate to reach out.